We first of all stabilize them. Some of them are anemic, they don't have enough blood. Some of them are malnourished because they have not been feeding well. Remember, they don't even have source of income because they cannot work to raise money because of the leakage and the smell. They cannot work, so they are so malnourished. So we try to build up their nutrition first. Some of them require blood transfusion, and then we take them through counseling because there are so many of them who are psychologically affected. In fact, some of them are on psychiatric drugs, so we take them through counseling, and then some of them require psychiatrists, so we have colleagues at the university who come here and see them and start them on treatment. And then once we have stabilized them, we perform the surgery. It takes about 2 weeks for them. Some of them take a month because the operation is very complicated, but the majority of them take about 2 weeks. And in those 2 weeks, we counsel them more. We try to train them about income generation, because remember, they have nothing, they have no source of income. So we teach them about how to raise, what they can do at their age. If they are young ones, we actually take them to school through a program called Beyond Fistula. And once they have gone to school, some of them are staff. We have about 7 of them working here at the hospital who are former patients. So once we identify some of those ones who are a bit older, who cannot go back to school, we train them how to save money, what kind of business they can do. So through a program called Beyond Fistula, we also start them a small business. So by the time they are leaving Gynocare, they have healed from the fistula. If they have not healed, we refer them back again for another second, third, fourth surgery. But if they have healed and they are not able to make it back home because of financial issues, we give them back transport. But we have given them some kind of training so they can do some income generation. That program has done more than 1,000 women through that kind of program, rehabilitation program. More than 1,000. School, even so young ones who are sexually assaulted, girls, went through primary school, high school. Some of them are actually in high school now, some are in college. So we go through formal education or informal for the older ones, and then for the ones who cannot even be trained, we just kind of give them advice on how to raise income through chicken rearing or goats or cow. So we try to give them that kind of training. So they have holistic care from surgery to income generation and reintegration back to their society. The national insurance NHIF covers a few patients who have the NHIF card, and this is a very recent development. Before, there was no fistula coverage in the NHIF, but for the last 2 years the NHIF covers fistula surgery. But 3/4 of our patients, actually more, even 80% of our patients, do not even have a NHIF card. That means they have no access to these NHIF funds. We do operate about 50 patients a month, and I feel that the numbers are out there still high because most of the patients fear to talk about this condition, which is very shameful. Leakage of urine and stool uncontrollably is a very shameful condition. So most of our patients fear to come out and talk about it. So there are so many in the villages, because I see mothers who have had fistula for 50 years who come here for surgery. And then of course the challenge of reaching out to women who have this problem is there. So we have really serious challenges in convincing women that this service is available, or even convincing them to say they have the problem first. So these are some of the challenges that we face, reaching out to those very hard, difficult areas to reach. Turkana, for example, Baringo, the East Baringo, West Pokot. So reaching out to those areas is quite challenging, but we hope with awareness, sensitization, community mobilization, then people might be able to hear this and come for treatment. Way back when I worked as a young doctor in West Pokot, many years back, the year 1999, 97, I saw the problems these women faced, fistula patients faced, and there was no doctor at that time. We had to wait for a year for a doctor to come from Amref. It's a doctor from Holland who could come and operate these women once a year. Then I found out that if we don't train, then we won't help these women. That's how I decided to go back to the University of Nairobi to train as a gynecologist, and then further my training in Addis Ababa Fistula Center. And that's how I actually came to Eldoret to kind of help women here and also help women in other countries, especially Malawi, Tanzania, which also have Uganda, which have the same challenges. So we do some outreach work in those countries to try also help these women get a successful surgery, and also train other young doctors to learn the skills of the procedure. The fistula surgery has not been very popular to doctors because most of the patients who have this condition, they are very poor women. They cannot pay for the services. And then initially there was a myth that this operation was very difficult, and the success rate was maybe 40%. But over the years, we have improved our success rate to 90% once we do these operations. So we hope this one can actually encourage the young doctors to learn the skills. The Minister of Health, I think, should come and kind of put up some effort in training these doctors to get the skills so they can actually help so many women who are in the villages who are suffering from obstructed labor, so they can get some kind of skills to really manage this kind of. But we don't have at the moment a training that is supported by the government. We only have NGOs that actually support training for fistula doctors. We don't have a program from the government so far. So I think it's maybe a good idea for our own people to support our own Kenyans who are really suffering from this kind of demeaning condition, so they can start a new life after the operation is done.
As a caregiver, actually, from interaction, we find many stories from this woman. For example, maybe a woman has suffered with fistula for 40 years, and here comes a case. It was a cell of obstetric labor, and she ended up losing even a child. Now she comes, she's childless, and the husband abandoned her, even they chased her away from their home. Even our own relatives abandoned her because of the condition. So as a caregiver, emotionally, you feel it traumatizes you as a caregiver.
What I can actually say is that when a mama is expectant, and really pregnancy is a very nice thing to mothers or to the society. At the end of the day, a mama wants to have a baby who is alive, and also she's alive. So if this mama is able to attend the clinic early enough, like after mama has confirmed that she's expectant, then she should be able to start the clinic immediately, not to wait for 3 months, not to wait for 4 months, but to just start the clinic immediately. Because at the beginning they are given vitamins that help to prevent congenital problems like big head, hydrocephalus, or spine problems like what they call spine bifida, where the parts are problem. So vitamins prevent this. So if a mama is given vitamins as early as even before she gets pregnant, these vitamins prevent mother from getting congenital malformation. Also, it helps her have a healthy baby. And then when she's at any clinic, her blood pressure is checked, her blood sugars are checked. At the end of the day, she escapes those consequences of blood pressure, which is really life-threatening, diabetes, which occurs in pregnancy, which is life-threatening, infections. So if she attends the clinic early and then she goes to the hospital for maternal delivery, labor and delivery, then she has a live baby, and she has her life is also safe. Then she also escapes from these injurious defects like tears, very bad tears, or she gets fistula. So that's my advice to mothers, to have an early clinic attendance to a recognized government facility or a private facility, so that she can be able to be checked mapema, and all the problems are checked in time, noted in time, and then prevented, so that safe maternity and delivery is actually given to this patient.